Doctor, just a second. On
Yes, yes.
YouTube.
Facebook. Yeah, yeah.
So should I
Yeah,
start?
we can
No,
start
no,
now.
no. Okay. Good evening and welcome to the expert crosstalk on Empagliflozin multi-benefits in multi-indication by multi-mechanisms. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, cardiology and endocrinology, which should bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to Emperor HF trial, as SGLT2 inhibitor may be considered as an important drug for HFrEF. To get the answer, let me introduce today's speakers. Yeah, today's speakers are Dr. Suvrit Jain and Dr. Ankur Batra, and I will moderate Dr. Shavik. Dr. Suvrit Jain is a consultant endocrinologist and diabetologist. Dr. Suvrit is specialized in diabetes mellitus, thyroid disorders, and disorders of growth and puberty, osteoporosis, and metabolic diseases. And Dr. Suvrit has got a special interest in diabetes type 1, insulin, obesity, insulin pump therapy, and menstrual problems. And he has passed his MBBS from Rohtak and MD in internal medicine from AIMS New Delhi and MD endocrinology from Lucknow. And his achievement is he has got a Best Resident Award in first year in AIMS New Delhi 2012. I welcome Dr. Suvrit in this expert web talk. Our next speaker is Dr. Ankur Batra, who is an interventional cardiologist and cath lab director, Nidan Hospital, Sonipat. And Dr. Batra has received several prestigious awards and also have several national and international publications in his credit. I welcome Dr. Ankur in this expert web talk. And I'm handing over the session to Dr. Suvrit to start with this presentation. Thank you.
So should I start?
Yes.
So hello everyone. I am Dr. Suvrit. I am a consultant endocrinologist presently working at my own center in Rohtak. I did my specialization in internal medicine from AIMS New Delhi, as already discussed, and post DM in endocrinology from SGPGI Lucknow. The topic for today is the upcoming and the new kid on the block, the SGLT2 inhibitors, and the molecule in focus today is empagliflozin. So we'll be discussing its various indications, its mechanisms of action, and the various data which we have from landmark clinical trials. So we can move to the next slide, please. So I'll be covering the endocrine aspect, and Dr. Ankur will be covering the talk from the cardiologist perspective. So we can go ahead, please. So these are the SGLT2 inhibitors. The four main SGLT2 inhibitors which are presently there in India and in use in clinical practice include dapagliflozin, canagliflozin, empagliflozin, and remogliflozin. So this is the flow diagram which just represents the first publication, the year of first publication. So they were introduced to us as early as 2008, but only since last 4 to 5 years, last 5 years, have their use been really significant. And after publications of major landmark trials, they have really become the cornerstone of diabetes management. So let's go to the next slide. This is just the diagram of a nephron, which shows the almost 180 liter per day amount of blood it passes through the proximal tubule, and almost 90% of the glucose gets absorbed in the proximal tubule. Passes almost 180 liters per day of filtrate passes through the nephron, the Bowman's capsule, and then almost 90% of it gets absorbed in the proximal tubule. So SGLT2 inhibitors, their main mechanism is that they inhibit the SGLT2 receptor, and which is primarily located in the proximal tubule, and this leads to increase in the amount of urine glucose, resulting in osmotic diuresis and glucoseuresis, resulting in decreased in blood glucose levels. There are multiple mechanisms. They act at various points in the ominous octet, which is classically described as to leading to the pathophysiology of diabetes. So this is just one primary mechanism. They act by multiple mechanisms, and they are very efficacious and effective anti-diabetic agents, as we will see further in the talk. Yeah, so we can move to the next slide. So these are the main three main SGLT2 inhibitors for which we have good landmark RCT data. Remogliflozin data is limited, so we'll be basically discussing these three gliflozins. So empagliflozin, the therapeutic dose is 10 to 25 milligrams. We can start with 10 and go to a maximum of 25 milligrams. It comes in two strengths. Dapagliflozin comes in 5 and 10 milligrams, and canagliflozin can be used from 100 milligrams up to a maximum of 300 milligrams. They are OD administration, all of them, and they reach their peak plasma concentration within 1.5 to 2 hours. And almost 60 to 70% of them are orally bioavailable. Metabolism is primarily through glucuronidation, and there are no active metabolites. Elimination pathway is through both hepatic and renal means. And SGL, the point which is very important here is that empagliflozin has a very high selectivity for SGLT2 receptor as compared to the other gliflozins. So we can call it the most selective SGLT2 inhibitor. And the other take home points are the doses I've already mentioned, from 10 to 25 milligrams, good oral bioavailability, and hepatic and renal elimination. So these are the salient points, the salient pharmacokinetic properties of the different gliflozins. So next. So we'll be basically discussing the data for empagliflozin. First, the phase 3 pooled data from the various phase 3 clinical trials, and then the landmark EMPA-REG. So this is just the compilation of the pooled phase 3 data, which shows the results for HbA1c, percentage change for from baseline in HbA1c in patients who have been started on empagliflozin 10 milligrams and 25 milligrams. The blue bars represent the 10 milligrams arm, and the 25 milligram arm is represented by the red bar. And on the top, we can see the baseline therapy. So, so we can have empagliflozin alone as a monotherapy, empagliflozin on the background of metformin, empagliflozin on the background of pioglitazone, empagliflozin on the background of metformin and sulfonylurea, and empagliflozin on the background of insulin. So what we can clearly appreciate from this diagram is that the placebo corrected change in baseline HbA from baseline is around ranging from 0.5 to 0.8 milligram percent. So they are good efficacious agents, and irrespective of the baseline therapy, they offer good HbA1c reduction, and all the differences are statistically significant. So irrespective of the baseline therapy, empagliflozin offered in all these trials offered a HbA1c reduction of almost up to 0.5 to 0.8%, and individually after correction for placebo, and it was irrespective of the baseline therapy. So in various anti-diabetic regimes, addition of empagliflozin caused a good HbA1c reduction as compared to placebo. Next slide. Similarly, there was a significant weight loss with empagliflozin. So the mechanism here is again glucosiuresis, osmotic diuresis, and ultimately weight loss. So these are agents which are very important for causing decrease in weight. So on one hand, we had sulfonylureas, which used to cause weight gain, but with the SGLT2 inhibitors, especially, weight loss is a very important property. And in obese patients with a baseline weight of 75 to 90 kilograms, almost 2 kilograms weight loss was achieved with correction to the placebo from the baseline. Next slide. Similarly, the change in the systolic blood pressures, because they cause osmotic diuresis and glucosidosis, there is decrease in intravascular volume, and that results in decrease in the blood pressure. So very often we find that addition of empagliflozin very drastically reduces the doses of antihypertensives. And that is again, on the other hand, we should be very cautious in patients who are having a very low cardiac reserve or who are on multiple antihypertensive agents, because they actually cause decrease in blood pressures, as is evident from this diagram, almost 4 millimeter of mercury in various arms. So again, emphasizing that the hypotensive effects of empagliflozin. Next. So this is a 12-week ABPM study, ambulatory blood pressure monitoring study with empagliflozin in diabetics who are hypertensives. And what we can clearly appreciate is both with 10 and 25 milligram, there is significant shift in there is significant separation of the two. You can see the significant separation of the two graphs at week 12, suggesting significant reduction in systolic blood pressure in the empagliflozin arms as compared to the placebo. So again, re-emphasizing the fact that they also are effective in reducing the blood pressures in patients who have comorbid hypertension. Next slide. So this is significant improvement in the diastolic blood pressure also. So what we have clearly seen is that they are good, effective agents from the glycemia point of view. They offer good HbA1c reduction. They offer weight reduction. They offer blood pressure reduction. And this blood pressure reduction is observed both in systolic and diastolic. And we have data from ambulatory BP monitoring, which shows the same. So again, re-emphasizing the multifold mechanisms through which empagliflozin helps in a patient who with diabetes and comorbidities. So uh, we can go to the next slide, please. So this is just a summary slide which shows that there is significant HbA1c reduction, significant reduction in the fasting plasma glucose, significant reduction in body weight, and significant improvement in the systolic blood pressure in various arms. So we have already discussed this. This is just a summary slide. Yeah, so we can go ahead, please. So coming to the safety topic. So one very important concern with SGLT2 inhibitors is genitourinary infections. So because they cause glucosidosis, there is definite increase in the risk of genital infections in patients who are on SGLT2 inhibitors, as is evident in this slide. There is increased number of patients with urinary tract infections. Severe UTIs or pyelonephritis or severe urosepsis is very uncommon. The UTIs which are there are usually mild and they can be treated easily. We should discontinue them in a case of active genitourinary tract infection, and we can reintroduce if there are no other risk factors for a recurrent UTI. And other common they can lead to volume depletion in patients who are, as I already mentioned, with limited cardiac reserve on multiple antihypertensives, diuretics, and very occasionally there is hypoglycemia. Usually, per se, they do not have any anti-hypoglycemic properties, but only when they are combined with other agents like sulfonylureas, insulin, that they result in hypoglycemia. Yeah. So hypoglycemia is again, prevention of hypoglycemia is again a very significant aspect of empagliflozin therapy. Only when they are added to an underlying sulfonylurea or an insulin regime, we should be cautious of hypoglycemia. But per se, they do not cause hypoglycemia. Next slide. So this is the landmark EMPA-REG trial. which changed the course of diabetes management in the past 5 to 6 years. It's the cardiovascular outcome trial with empagliflozin conducted in patients who were having type 2 diabetes and very high CV risk. Most of them, large majority of the patients were having clinically proven CVD, and as we'll discuss, this it showed significant improvement in the cardiovascular outcomes with improvement in glycemia, and it changed the course of diabetes management since then. We'll discuss the trial. Next slide. So these are the primary outcomes, the 3-point MACE, which is usually taken as the primary vascular outcome. Uh, it's a composite of unstable angina, non-fatal stroke, and non-fatal NSTEMI. And there was a significant improvement in the number of patients who had these events as compared to placebo. So a significantly lesser proportion of patients on empagliflozin had these events as compared to placebo. It also reduced the cardiovascular death and all-cause death. So this was again very significant, that this trial showed significant mortality benefit, and from the cardiovascular point of view and all-cause mortality also. And the last important result was hospitalization for heart failure. So there was significant improvement in patients requiring hospitalization for heart failure. So these were the hard endpoints which were achieved with empagliflozin in the EMPA-REG trial: reduction in 3-point MACE, reduction in cardiovascular mortality, all-cause mortality, and reduction in hospitalized for heart failure. So since then, there has been a plethora of trials with multiple SGLT2 inhibitors and numerous CVOTs, which will just take a snapshot of that in the next slide. But just to emphasize here that none of the SGLT2 inhibitors could achieve a CV mortality or an all-cause mortality benefit. It's argued that probably the patients in EMPA-REG were very high risk for cardiovascular events, and that is why it has resulted in such a significant result in CV mortality and all-cause mortality. Maybe it is molecule specific or class specific, that remains to be seen, because the other CVOTs done with canagliflozin and dapagliflozin did not show mortality benefit, although their baseline population was significantly different. It was heterogeneous, and there was a mixed population with patients, a significant majority of patients who were not having proven CV disease or who were not very high risk for CV disease. So that may account for the heterogeneity of results. But till date, empagliflozin is the only gliflozin to offer. There is hard data with empagliflozin for mortality benefit. Yeah, we can go ahead, please. So there were exploratory renal outcomes also, which showed decrease in the incidence of doubling of serum creatinine and proteinuria, and progression of microalbuminuria to macroalbuminuria. So we have a dedicated trial coming up, results expected by 2022, the EMPA kidney, but which is dedicated to the renal outcomes trial. But like most of the other CVOTs which I'll discuss, EMPA-REG showed significant renal involvement improvement in patients with diabetes and underlying CAD, and that is something which is very important. So they are just not anti-diabetic agents; they are cardiovascular agents and renoprotective agents as well. So yeah, you can go ahead. So in patients with type 2 diabetes and high CV risk, empagliflozin, in addition to the standard of care, reduced heart failure, hospitalization of and risk of CV death, with consistent benefit observed in patients both with or without heart failure. So even in patients who did not have a underlying heart failure, who did not have a proven CVD, who did not have a evidence of ischemia on echocardiography, who never had history suggestive of a coronary artery disease, even in them there was mortality benefit. So suggesting the wide array of patients in which empagliflozin showed a mortality benefit. So quite early in the diabetes should reintroduce the empagliflozin so as to achieve mortality benefits in even in low risk patients, or even in patients in which heart failure and there is no evident heart failure, or there is no evident coronary artery disease, right? So this is the another very important conclusion from the EMPA. We can move to the next slide. So as early as so it showed CV benefits quite early. So there was an early separation of the incident of heart failure for hospitalization. And the curves in the curve and the AMPA curve and the placebo curve separated quite early. So uh, so so we can clearly see that empagliflozin acts within weeks, and its action is quite rapid. The change in metabolics and the dynamics of it is quite rapid, and uh, there is a very drastic and significant improvement in the cardiovascular profile of a patient. And the benefit in reducing the risk of heart failure, CV death, emerged within weeks of treatment. So this is something which is very important, that as early as few weeks we can start having benefits from the empagliflozin. Yeah, we can go to the next slide, which will have the diagrams. Next slide, please. So there was significant reduction in risk with empagliflozin as compared to placebo, and it reached significance at day 17. So by the day 17, there was reduction in it. There was separation of the curves, the placebo curve and the EMPA curve, and there was a significant improvement in the risk for hospitalization. And by day 27, we had benefits for heart failure hospitalization and CV death. So, it's reached significance, the benefit on CV death reached significance at day 59. So, the take home point is that within a few weeks, we can start having very beneficial effects on heart failure hospitalization and cardiovascular mortality. And this is again something which is very important, suggesting the fact that it is not for many years that we have to wait for beneficial effects. We start having beneficial effects, cardiovascular benefits, quite early. So we should be very prompt in initiating patients so as to achieve maximum benefit with these agents. Next slide. So this is the list of CVOTs. The blue bars are the gliptins, the yellow bars are for the GLP analogs, and the red bars are for the SGLT2 inhibitors. So we had the AMPAREG, which was published in 2015. We had Canvas published for canagliflozin, published in 2017, and then we had the a renal uh, outcome trial with canagliflozin, which was the Credence. And then we had Declare Timi with dapagliflozin. And most recently, we have had the Vertis CV with artugliflozin. So these are the various CVOTs with with the various SGLT2 inhibitors. I'll not be going into the details of the other CVOTs with DPP4 inhibitors and GLP analogs. But yeah, these are the 4 or 5 CVOTs which have been seen. As there was significant benefit, there was significant improvement in heart failure for hospitalization with all the gliflozin. So it was probably the heart failure results were almost uniform, but CV mortality benefit and all-cause death mortality benefit was only seen with EMPA. So next slide. So it acts through multifold mechanism. It's a molecule with multiple pleiotropic effects. It decreases weight and decreases visceral adiposity. It decreases oxidative stress. It decreases uric acid. It decreases. It has beneficial renal effects, reducing to reduce albuminuria. It has very prominent cardioprotective effects with favorable cardiac remodeling. It increases the insulin sensitivity. It decreases blood pressure and arterial stiffness. So it's a molecule with multiple actions at multifold pathways, predominantly affecting weight, blood pressure, glucose levels, insulin sensitivity, having a cardioprotective and a renoprotective effect, having a favorable effect on the endothelium and the arterial stiffness, and uh, having a direct effect on the myocardium, leading to favorable cardiac remodeling. We'll be seeing the results with the Emperor trial, which I'll be discussing in the subsequent slides, that it directly acts on the cardiomyocytes, uh, and there is a very beneficial cardiac remodeling which it offers. So, that offers a very direct mechanistic uh, mechanism mechanism for its benefit and for its cardiovascular benefit. Yeah. So next slide. So these are the I've already discussed the these are the landmark CVOTs. There was significant improvement in heart failure for hospitalization, CV death, and renal outcomes with Empareg. With Canvas, which was done with Empagliflozin, there was significant improvement in heart failure for hospitalization for heart failure, but no mortality benefits. Uh, Canvas also had beneficial renal outcomes, and subsequently there was a dedicated trial which was Credence. So it also proved beneficial renal benefits with canagliflozin. And regarding Declare to Me, we have again heart failure for hospitalization was hospitalization for heart failure was reduced. There were beneficial renal outcomes. However, there was no mortality benefit, and Ertugliflozin actually did not reach any endpoint in the Vertis-CV trial. So the three main gliflozins, empagliflozin, canagliflozin, and declarative, they all have cardiovascular benefit in the form of reduction in hospitalization for heart failure. They are beneficial renal outcomes. Uh, the mortality benefit in cardiovascular mortality benefit and all-cause mortality benefit was only observed with the Empareg. Could be possibly because of the heterogeneity of population. It's quite possible that the other two gliflozins could not reach the endpoint because of a significantly uh, mixed population, or a population baseline population which was at a lower risk as compared to the Empire. Yeah, next slide. So all the guidelines, they have shifted from metformin as the first line therapy, followed by addition of second line agents. And more we are moving towards a combination therapy right at the starting. And especially if there is an underlying ASCVD or patients who are having very high CV risk, SGLT2 inhibitors along with metformin are the agents of choice as according to the ADA. Even the 2020 ADA says the same. Yeah, next slide. So in patients who are having high ASCVD risk or who are already having proven CVD, SGLT2 inhibitors and metformin, or GLP receptor agonists or and metformin, continue to be the agents of choice as is shown in the ESC guidelines. And the 2019 ACC-AHA guidelines, they suggest metformin followed by sequential addition of SGLT2 inhibitors if patient has ASCVD or if there are very high CV risk factors. So the take home point here is that all the guidelines are moving towards a primary metformin plus SGLT2 inhibitor therapy in patients who are already having CV disease or who are having a very high risk of CV disease, and they are the agents of choice in patients with an underlying CV comorbidity. Yeah. Next slide. So I think my part is over. Hello. Hello.
Yeah,
Yeah,
good
Dr.
evening.
Batra. Yeah, is
Yeah,
this
good evening, Dr. Suvrit. Good evening.
Yeah.
It
Hello,
was
sir.
a very well given talk.
Yeah.
It's actually one of the few drugs that we both agree on. I think So it is something that has proven consistently over past 3-4 months that the statistics and all, they have come up so strongly supporting the use of SGLT2 that I actually did not wait for the guidelines thing, but I shifted over all my patients. Practically 90% of my patients are on some or the other SGLT2 inhibition. I hope the same must be with you as well.
Yeah, definitely.
So yeah. So I would, on such a beautiful topic, I would like to give my perspective as a cardiologist. And we know that the landmark epidemiological study, Framingham Heart Study, it stated that the highest risk of heart failure in the patients with diabetes over 30 years of follow-up. That means that there is a huge risk of heart failure in patients with diabetes, with or without any evidence of acute coronary syndrome. There are multiple pathological factors behind it. We'll not go into that, but heart failure remains a very dreaded outcome for all the patients who are having diabetes. They are prone to preserved as well as reduced ejection heart failure, and it's a more common outcome as evidenced by all the other trials, more common than MI, stroke, or death in all the diabetic trials. So at this point of time, we understood that glycemic control plays a huge role on the CV outcomes, and so all the major trials, Accord, Advance, UKPDS, and all, they all favored the more intensive diabetic and glycemic control in patients. And all those patients, they were having the patients with cardiovascular disease, those patients, the stricter glycemic control was definitely having a better outcome as compared to a more less intensive glycemic control. Uh, Heart failure outcomes in clinical trials of glucose lowering agents in patients with diabetes, they all showed that multiple drugs have been shown to be useful, but two of the drugs, or two or three drugs, stand out amongst all the other crowd. And one of them is GLP-1 agonist, and the other one is SGLT2 inhibitor. So in the recent time, the strongest association with the reduced MACE as well as better diabetic control has come up with SGLT2 inhibitor. It has been evidenced, as discussed earlier, with Empareg and DAPA HF, and multiple trials have come up, Emperor trial and all those things. But it is pretty much clear that SGLT2 inhibitors are going to stay, and it's one of those drugs that is going to provide real benefit to the patients in long run. Heart failure outcomes in clinical trials of glucose-lowering agents in patients with diabetes, they showed that patients with events were much lesser in number when they were on empagliflozin. So that itself gives a huge indication that as compared to placebo, empagliflozin, like an SGLT2 inhibitor, they will lead to lesser heart failure outcomes in patients with diabetes. We know that we had a fair idea that yes, SGLT2 inhibitor does help the cardiovascular disease patients, but how do they actually do that? So there are multiple pathophysiological pathways. It's a kind of pluro. There is a kind of what do you say? There's a kind of pleiotropic effect which helps the SGLT2 inhibitor to give this kind of benefit. Natriuresis, improved kidney function and cardiorenal physiology, reduced preload, afterload, and reduction in LV wall stress, and reduction in interstitial edema. All of them combined, they'll give an outcome of reduced heart failure hospitalizations and reduced heart failure associated mortality in patients with diabetes. So up until now, we were thinking that SGLT2 inhibitor, they are useful in cardiovascular disease patients. There was a huge discussion whether it will be useful with or without diabetes also. So then the analysis has been divided into basically 4 kind of patient subsets. One, a heart failure with preserved ejection fraction with diabetes. Then heart failure with reduced ejection fraction with or without diabetes. So consistently over all the 4 groups, SGLT2 inhibitor has shown benefit, and the maximum benefit has been shown in patients with heart failure with diabetes, but there was a superiority gives way to the use of SGLT2 inhibitors as a heart failure therapy, even if the patient is a non-diabetic. So it's a very good outcome out of all the trials. As we all know, there are two therapies for heart failure. It can be either preventive or it can be either therapeutic or treatment therapy. So therapies which only prevent heart failure are statins, blood pressure control. SGLT2 inhibitor comes in those kind of in that category. You prevent the ischemic events. You prevent LV remodeling. They all lead to prevention of heart failure. What if the patient has already established heart failure? Drugs like sacubitril, valsartan, ivabradine, CRTs, ICDs, and MRAs and all, they actually treat the patient. They do not prevent the further heart failure. ARNIs and all, they sometimes, there is actually a great evidence that ARNI can reverse a component of heart failure. But again, it does not prevent, it treats the heart failure. Then came up a very beautiful trial. I think it is one of the favorite trials that I've read in last year. That is Emperor Heart Failure Study. And the design of the trial was in a way that there were two kind of subgroups, basically. One is Emperor Reduced and Emperor Preserved. In Emperor Reduced, they took all the patients with reduced ejection fraction of less than 40% and with an elevated NT-proBNP. That means that the patient was already having strain, or the patient was having some symptoms of heart. He was not yet acute decompensated, and he already was medical therapy. So that was the subset of patients who were taken into Emperor Preserved. They took all the patients who were having EF of more than 40%, and they were under stable condition. Of the following, they either had a structural heart disease, or they had a hospitalization 12 months prior to screening, and they had an elevated Emperor Reduced trial. And in an Emperor Reduced trial, they took around 3,730 participants for 20 months. In Emperor Preserved, they took around 6,000 patients and followed up for 2 years. And they started with a dose of 10 mg empagliflozin. It was a randomized double, the trial was to assess the safety and efficacy of empagliflozin in patients with symptomatic heart failure, ejection fraction, irrespective of diabetic status. So this was the crux of this disease, is diabetic, and the patients having heart failure, how efficacious is SGLT2 inhibitor going to be to prevent any, CVOT outcomes. So study design was the patients were randomized, 1:1 fashion, and into placebo or into empagliflozin. Total number of enrollees, as I told earlier, was roughly around 3,730, and the median follow-up duration was 16 months. The endpoints that they had fixed was, our primary endpoint was a composite of CV death or heart failure hospitalization. First secondary endpoint was total, first and recurrent heart failure hospitalization. They also had a subgroup analysis of, decline in the glomerular filtration rate over time. So that was the secondary endpoint. Inclusion criteria was all the patients who were in NYHA class 2, 3, and 4, more than 18 years of age, and an EF of less than 40%. And they have had heart failure related hospitalization within 12 months. And the NT-proBNP was high. So if the patient is having some arrhythmias like atrial fibrillation, the above threshold were doubled, and then the patients were included in the trial. So basically a kind of patient who is adult patient in NYHA, 2, 3, or 4, and had a heart failure hospitalization within the last 12 months. Exclusion criteria was, if the patient had an acute insult of the myocardium or an acute coronary syndrome within last 3 months, or a stroke or a TIA within last 3 months, patients who are already listed for heart transplantation, any patients who are having some structural cardiomyopathy like infiltrative cardiomyopathy or muscular dystrophies or some valvular heart disease, those kind of patients were excluded from the EMPERA study. The principal findings which we got out of EMPERA study was the primary outcome, CV death and heart failure hospitalization for EMPA versus placebo was 19.4% versus 24.7%. This had a p-value of less than 0.001. So it was a highly significant reduction in the primary outcome. So remember, our primary outcome was a CV death or heart failure hospitalization, and with 19.4 versus 24.7 with a highly significant p-value, it was a successful finding. CV death CV death as well as heart failure hospitalization, when compared separately, the heart failure hospitalization had a more impact on the primary outcome as compared to a death, but nonetheless cardiovascular death outcome was definitely improved. If we put it in a primary endpoint, they had a 30% reduction in the risk of secondary endpoint, and they had a 50% reduction in the future renal events. So they were all very promising numbers, which ultimately led us to place of SGLT2 inhibitor in the treatment of diabetic, in the treatment of heart failure patient, irrespective of their diabetic status. And we studied the cardiovascular outcomes. A subgroup analysis also studied the renal outcomes, and they studied that they found out that it prevented both serious heart failure as well as serious kidney failure events. So the future decline in the eGFR was much less when the patient were on SGLT2 inhibitor. So how does it do it? We know there's a pleiotropic mechanism behind all this, but how does it exactly do it? So there are some direct effects of the myocardium, and there are some systemic effects. So direct effects on myocardium, they are all very biochemical pathways with with sodium channels, and increase mitophagy and autophagy, decrease inflammation and decrease apoptosis of the cells who are not getting fibro. So that had a potential direct myocardial effect of SGLT2 inhibitor. The systemic effects were improved renal function, increased provascular progenitor cells, and increased EPOs, decreased sympathetic nervous system, and improved energetics. So these all mechanisms in toto, when came out together, they led to reduced heart failure complications in future. This is a slide. There's a histological analysis, actually a porcine model. And if you see on the left side, you will see all these red lines. These are the collagen stains. And this on the right side is it's the same thing who has been treated with SGLT2 inhibitor. So the picture E has much less collagen as compared to the picture D, which is on your left side. It clearly indicates the patient was undergoing in heart failure was much reduced when the patient was put on SGLT2 inhibitor. Although it is a porcine model, but the results can be extrapolated to human beings as well. So EMPERA reduced trial showed that empagliflozin is superior to placebo in improving heart failure outcomes among patients with symptomatic stable heart failure with reduced ejection fraction on excellent baseline guideline directed medical therapy. So the patient was already on your GDMT, and the patient, if you want to increase the survival, then when you add SGLT2 inhibitor, there was a better cardiovascular outcomes in future. The EMPERA reduced trial with empagliflozin will have a major impact on management of patients with chronic heart failure, whether or not they have diabetes. There is now a compelling evidence that SGLT2 inhibitors should now be added to currently recommended this disease. This is the infographic that I've already discussed. This is the secondary outcomes. They consistently came down with everything. Total hospitalizations were reduced, composite all-cause mortality was reduced, but all-cause mortality, I remind you, all-cause mortality not significant. The p-value was more than 0.05, but still there was a numerical reduction in the all-cause mortality. There was a reduction in new onset type 2 diabetes mellitus in the patients who were pre-diabetic. There was a significant change in the HbA1c, and there was a reduction in systolic blood pressure, and there was almost similar confirmed hypoglycemic event. So it is very important term here, confirmed hypoglycemic. But that is very small of the bigger picture here. The results of this trial indicate that empagliflozin is superior to placebo in patients with heart failure and who are already on GDMT, irrespective of diabetic status. The benefit is primarily driven by reduction in heart failure hospitalization function appeared to benefit. Even though SGLT2 inhibitors were introduced as just a second. Yeah. So even though the SGLT2 inhibitor were introduced as a diabetic management drug, but these trials have definitely solidified their place as a heart failure therapy as well. This trial enrolled a dedicated heart failure population. It was a multi-centric, all over the world situated trial. So it had a very inclusive kind of population and showed benefit in this patient population irrespective of the diabetic status. These drugs will likely have a prominent role in future heart failure management guidelines. Thank you.
Yeah. Thank you, Dr. Batra and Dr. Suvrit, for your wonderful presentation. So we have two questions. First question is Dr. Suvrit, as an endocrinologist, actually, do you think after this Emperor-HF trial, empagliflozin will be a game changer compared to the metformin?
Yeah, please repeat your question.
Yeah, after this Emperor-HF trial, do you think empagliflozin can be a game changer compared to the metformin?
So I don't get the question. It's especially a game changer in cardiology. In cardiology, it's a game changer.
No, compared to metformin.
To compare it to metformin. In cardiology, yes, it's a game changer. It can be added on to the classical heart failure therapy of beta blockers, aldactone, spironolactone, ARNI, and so it's an important addition in that, and even in patients who are non-diabetic. So and in patients who are diabetic with preserved ejection fraction, we already had quite a bit of data from the EMPA-REG. So definitely it's a game changer, especially in cardiology, where non-diabetics with heart failure will now have an additional molecule to improve their heart failure outcomes and improve their mortality prospects, apart from the already proven therapies of which include beta blockers, ARNI, ACE inhibitors, ARBs, diuretics, and other therapies like statins and control of hypertension. So all apart from, it's just a very important addition to already existing guideline-based management therapy in cardiology. It's a game changer there. Yeah.
Okay, thank you. Dr. Ankur, can we prescribe SGLT2 inhibitor in patients without established CVD or having multiple CV risk factors?
So, so this is what I want. I was listening to Dr. Suvrit just now. Dr. Suvrit, I would just like to ask one thing, or rather discuss something, that patients in India who are already having a high risk of cardiovascular disease, and if they turn out to be diabetic, type 2 diabetes, a high metabolic risk factor diabetes, those kind of patients. So in those kind of patients, I think for from the diabetic perspective also, if the patient is not having an established cardiovascular disease, but if the patient is having a let's say more than 7% ASCVD 10-year risk, and he's a smoker, or he's an obese, or he has a family history, those kind of patients I think would be a very ideal kind of subgroup of population who would benefit from this kind of drug.
So
Because
actually, this is not a subgroup. This is probably a large
yeah,
majority of
yes,
patients.
yes, yes,
And
yes,
in these patients, we have enough data from the EMPA-REG, from various other CVOTs, to suggest that even in patients who have multiple risk factors, SGLT2 inhibitors plus metformin should be the primary anti-diabetic therapy, unless there are contraindications, unless there are tolerance issues, and or unless there is affordability issues. So in
yeah,
ADA 2020, only when there is affordability issues should sulfonylureas be considered as a primary therapy. In patients, in all patients where we need to reduce CV risk, where we need to reduce weight, where we need to have a compelling need to reduce hypoglycemia, so that forms almost a huge majority of patients. SGLT2 inhibitors, along with GLP analogs and metformin, would continue to be the
yeah.
primary anti-diabetic therapy.
So I completely agree with you. This is what I was getting to when you ask this question, Shovik, that most of the patients which we encounter in our OPD are of these category only, and definitely empagliflozin cannot be taken lightly in those treatment guidelines, until unless, as he rightly said, the affordability comes into picture. That is for Lupin to decide when to reduce the drug prices. But I think
Yes, yes.
it's a beautiful drug. Yeah.
Yeah, thank you. And moreover, for the audience, there is no more question. So for the audience, sir, any safety precaution you prefer actually while you this one while you prescribing SGLT2I like empagliflozin? Any safety precautions to be taken in matter of
So
cardio?
SGLT2 inhibitors, there are some very important precautions which we must see. We should carefully select a patient. Although we can give SGLT2 inhibitors to a huge majority of diabetic patients, but there are some patients where we should actually avoid SGLT2 inhibitors. So these are patients who are pregnant. These are patients who are having insulinopenic, who are having type 1 diabetes, who are having history of recurrent diabetic ketoacidosis. There is risk of euglycemic diabetic ketoacidosis. Patients who are having recurrent UTIs. So there, I would not try to challenge it with SGLT2 inhibitors. Patients who already have had a genitourinary infection with SGLT2 inhibitors, and on reintroduction, they again have an infection. So those are the patients where we will try to avoid SGLT2 inhibitors. Once we select our patients, then probably the only things which we must see are the EGFR. It should be, although we have more and more data that even up to EGFR of 20, as in the Emperor trial, we are having safety of SGLT2 inhibitors, empagliflozin, but we should see the EGFR, and we should caution the patient that he or she should take plenty of fluids unless there is a proven cardiac comorbidity in the form of heart failure with reduced ejection fraction, where it is likely to precipitate a fluid overload. And thirdly, to maintain a strict genital hygiene. We should explain that you can have belanoposthitis in males and vaginitis. We should explain the symptoms, and we should tell the patient that you should immediately report to the physician if you have these symptoms. Many a times I have seen patients continuously having these symptoms, and they just don't know that this is because of this drug. So it's the physician's duty to counsel the patient. And many a times mild irritative lower urinary symptoms, mild dysuria, is often neglected, and I've seen some patients having very severe urinary infections going into a perineal abscess once. I've seen one patient. So we should all counsel, we should have a detailed counseling session of about 5 minutes about the various side effects of SGLT2 inhibitors. At times, many of the patients have severe asthenia and weakness with these drugs. So, and they go to multiple physicians, get tested for everything, and ultimately it is the SGLT2 inhibitor which is causing the fatigue and asthenia. So all these things, they must be carefully explained, and ideally we should have one person who should in the OPD who should tick all the boxes, explain everything, just like a diabetic educator, because in a busy OPD it's not possible to explain all of them, but all these things which I mentioned, they must be very carefully explained to the patient, because these
Yeah,
are new drugs, and many of the old physicians they are not aware of the side effects and the side effect profile. So again, explanation of these is very important. Yeah.
yeah. Thank you, Dr. Suvrit. Actually, the thing is, most of the patients, the counseling is very important, as you have rightly said, because most of the patients spending their time and money behind gynecologists and dermatologists to treat these causes, because some of
Yeah,
the patients don't know that that may be due to the SGLT2 inhibitor. I think so.
yeah, yeah, that
Yeah,
is very important.
it's very important, right? Dr. Ankur, any on cardiology perspective, any safety precaution for cardiology perspective?
So all the safety points that he mentioned, they are they hold good in cardiology as well. But
Yes.
there is one thing that we need to take care is that patients who are having reduced ejection fraction, they are already they are on some kind of diuretic. They are on most commonly they are on loop furosemide or loop diuretic kind of
Yes, yes,
uh,
yes.
and there is always a risk of hypovolemia, and there is always a risk of patient going into renal failure because of hypovolemia. So I have seen and I have experienced those things, although the risk profile says that it is very less, but I have seen a lot of these patients getting into hypovolemic renal failure, number one. Number two, recently, I think around 1 week back, there was a trial that was published that was, I think, Recede HF. That Recede HF trial, that was a cardiology trial in which the patients who were already on loop diuretics and was started on SGLT2 inhibitor. So, what was the impact of addition of either drugs on the therapy or on each other? So that was a trial that actually studied the indication between the diuretic and SGLT2 inhibitor, and they found out that SGLT2 inhibitor, when given along with a loop diuretics, they lead to increased natriuresis, number one, but natriuresis settles by week 6. But there is a disproportionate increase of urine output that sustains up to 6 weeks. So definitely it begs the question that we have to adjust our dosage, number one, and number two, if given both the options, I would rather put the patient to SGLT2 inhibitor, because loop diuretics have not shown mortality benefit. Mortality benefit has been proven by SGLT2 inhibitor. If the patient is, let's say, in class 2 or class 1, I would not give class 1, but class 2 NYHA patient, mild symptomatic, I would definitely try to get away with only SGLT2 inhibitor and not put him on loop diuretic, so that patient does not go into hypovolemia. So that is one thing that we have to be very careful about.
One point I like to mention, because
Yes.
most of diabetic patients coming to me, they have underlying CAD and heart failure. So orthostatic hypotension is something which we must be wary of because of hypovolemia. So they are
Yes.
on loop diuretics, they are on beta blockers, they are on ACE inhibitors, ARNI, ARB. So many a times I have seen SGLT2 inhibitors precipitating a severe orthostatic hypotension. So that is something which we must be wary of, and we must understand that orthostatic hypotension is something which we must be keeping in mind. Other thing is, just like Dr. Ankur said, maybe we should keep following the blood pressures, the supine and the orthostatic blood pressures, and consider reducing the doses of antihypertensives and diuretics, because many a times they come to the OPD with blood pressures of 90/50. So yeah, these are the two things which come to my mind from a cardiology perspective.
Yeah. Thank you, Dr. Suvrit, Dr. Ankur, for this wonderful presentation, sharing your experience and closing the session, because as there is no question. So thank you on behalf of Lupin. Thank you both for sharing your experience and wonderful presentation, and we'll see in the future meetings. Thank you very much.
Thank you. Thank you
Good
so
day.
Yeah.
much.
Thank,
Yeah.
thank you.
Good day.
Thank you.
Yeah.
Bye. Bye, Dr. Suvrit. Bye.
Bye. Bye,
Bye.
doctor.
Bye. Take care. Bye.